Hi, my name is Brigitte Ordóñez and my topic is refining antithrombotic therapy for atrial fibrillation and acute coronary syndromes or PCI. The definition. Antithrombotic therapy is the fundamental treatment to prevent thrombotic complication and death in various cardiovascular disorders. Acute coronary syndrome is the result of an obstruction of a coronary artery, while PCI, percutaneous coronary intervention, in atrial fibrillation is a procedure used to restore blood supply to the heart. Both cases are associated with the need for antithrombotic therapy.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries, induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Application in medicine. Approximately in 1 in 5 persons with atrial fibrillation will undergo percutaneous coronary intervention or have an acute coronary syndrome. Anticoagulation in such patients is challenging.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 mg dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 mg dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 mg dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros and cons. In pros, it has been proven that dual antithrombotic therapy reduces the incidence of recurrent ischemic events and stent thrombosis. Cons are less effective in reducing the incidence of cardioembolic stroke associated with atrial fibrillation.
Among the many late breakers that were shown at ACC, one trial was called Gemini ACS. Gemini was focused on what is the optimal antithrombotic strategy after an ACS. We have, for many years, we've used dual antiplatelet therapy combining a P2Y12 inhibitor and aspirin. Aspirin, we know, is a cheap agent. It has substantial efficacy, but it's also an agent that creates bleeding, particularly GI bleeding. On the other hand, we have theoretical and clinical evidence that combining antiplatelet therapy and low-dose anticoagulation might be extremely beneficial. Specifically, in the Atlas ACS trial program, combining rivaroxaban with dual antiplatelet therapy of clopidogrel and aspirin was associated with a substantial mortality reduction, close to 40% mortality reduction, something that's really very impressive. The problem is that there was a price to pay for this efficacy, which was a very substantial increase in bleeding as well. And so Gemini tried to address the question of, can we drop aspirin and replace aspirin with very low dose anticoagulation using a factor Xa inhibitor such as rivaroxaban and get the best of both worlds? Maintain the efficacy, if not increase the efficacy and lower mortality, and do this at an acceptable rate of bleeding. So we designed Gemini ACS as a stepping stone to a large phase 3 trial, which I believe should be a mortality trial. This is a phase 2 trial looking at the feasibility and the safety of this approach, and the primary outcome was bleeding, TIMI significant, clinically significant bleeding, to have some sensitivity and power. And the trial randomized approximately 3,000 patients receiving a P2Y12 inhibitor, either ticagrelor or clopidogrel, to being randomized to low-dose aspirin or low-dose rivaroxaban. The bottom line is there was no difference, no statistically significant difference in bleeding between the two arms, overall, as well as across the two strata receiving ticagrelor and clopidogrel. There was no difference either in an exploratory composite ischemic endpoint trying to seek out whether efficacy was maintained, but the trial was underpowered for this, and I think these conclusions have to be viewed as very exploratory. So I think this is exciting because it shows that for the first time in 30 years, we have an antithrombotic strategy that is safe and does not incorporate aspirin and has the potential to be tested in a large phase 3 trial to see whether we can further reduce cardiovascular mortality post-ACS. I think there's a promise here that deserves to be explored in a large phase 3 outcomes trial.
Issue apply in Ecuador. In Ecuador, the use of a direct inhibitor plus a P2G12 receptor inhibitor without aspirin is considered the most appropriate strategy for a patient with atrial fibrillation. And vitamin K antagonists combined with an antiplatelet agent are avoided to avoid bleeding. Conclusion. In patients with atrial fibrillation and a recent acute coronary syndrome or PCI treated with P2 G12 inhibitor in antithrombotic regimen that include apixaban without aspirin result in less bleeding and fewer hospitalization without significant difference in the incidence of ischemic events than regimen that include a vitamin K antagonist, aspirin, or both.
So patients with atrial fibrillation have an increased risk of cardiac thromboembolism and need oral anticoagulation to manage that risk. But we have a challenge when a patient's had an acute coronary syndrome or needs percutaneous coronary intervention, because in those patients there's clear evidence base for dual antiplatelet therapy with aspirin and a PCI-12 inhibitor. And so there's an indication on the one hand for an oral anticoagulant and on the other hand for dual antiplatelet therapy. And so what we've tended to do is combine treatments into triple therapy. But the challenge here is that we know that incurs a high bleeding risk when we combine triple therapy. And what has been the gap in the evidence is knowing whether we can cut back, just use two agents to manage thrombotic risk, both the risk of cardiac thromboembolism and the risk of stent thrombosis or further coronary thrombosis. And so this is the real challenge that has led to a lot of uncertainty in the community as to what the best regimen of antithrombotic therapy is for which particular patient. There have been many large studies that have looked at the role of non-vitamin K antagonist oral anticoagulants. We've got a number of agents now, apixaban, rivaroxaban, dabigatran, edoxaban, and these agents have all in their large phase 3 trials shown superior safety compared to vitamin K antagonists, predominantly warfarin. And particularly there's a lower risk of intracranial hemorrhage with the NOACs compared to the vitamin K antagonists. And this has led to increasing adoption of these new agents, which have some advantages also in terms of not needing regular monitoring of coagulation in order to set a dose. The doses are determined according to renal function and other clinical characteristics. But most patients, the majority of AF patients, requiring a single dose of these NOACs in order to achieve superiority compared to agents such as warfarin.
Thank you.